just like essentially the paper that I will present to you is almost 20 years worth of, working together to solve problems. And so it's very exciting. They face enormous challenges, and they were able to do a very, very nice research project with very limited resources. And it's really, I'm inspired by the work that they did with almost no funding.
Dhiren has not visited Vivek and Dr. Ashok, I think, at HRDC. You have not seen their center. It's an amazing place.
I have not seen, like Ashok is all the time inviting me, but unfortunately I have not accepted. But I must visit their place, because even Vivek, when he met us at at China, he showed us the great work they are doing. There was one presentation about that.
Yes. I know. I'd like to welcome you. I mean, Dave is very, very humble. Dave is my mentor, but more importantly, he's my brother. He's a part of our family. So everything that I've been able to write and all, without Dave's mentorship, I would have never been able to do that. And, we have a lot of collaborating on a lot of projects, and, his experience and my dad's experience put together, it really helps us, those of us who are on the ground and trying to look at all these things. It's I've learned so much from him, but more importantly, we are the same family. We just live in two different parts of the world.
I think let's begin, Rujita. I think it's 8 o'clock.
Yes, so we'll have
begin with the introduction.
Yeah. Let's have Dhiren Bhai welcome everyone, and then I'll read out Dr. Spiegel's introduction.
Yeah, good evening, Dr. Spiegel and Dr. Sponsor. Welcome to this unique program of Pediatric Orthopedic Society of India and Wadia Children Hospital. And it's unique in a way that it is not a journal club which we routinely have. Here we want you to share your insight with us. And when you share about your papers, please tell us something more which is not there in the paper. So with that, I request Dr. Rujuta to introduce our esteemed faculty. So over to you, Dr. Rujuta. Thank you.
Yeah, thank you, Dhiren Bhai, and welcome everybody on this really lovely and very, very special Meet the Authors session. I think today we are privileged to have two very, very senior stalwarts and two topics which are really close to everyone's heart. I think we're definitely going to have good pearls of wisdom come out of both these topics today. But as is my pleasant duty, I would love to introduce Dr. David Spiegel, who's actually a huge, huge name in the field of clubfoot and not unknown to anyone really speaking. But it's a very, very impressive CV. And I'd like to say that he works as a pediatric orthopedic surgeon at the Children's Hospital of Philadelphia, specializing in neuromuscular diseases, trauma, and spinal deformities. He's a professor of orthopedic surgery at the Perelman School of Medicine and the University of Penn Center for Global Health Scholar. He's attended Duke University for College Medical School and Orthopedic Surgery residency training, and then completed both a research and clinical fellowship in pediatric orthopedics at Children's Hospital of Philadelphia and University School of Pennsylvania. He served as an honorary consultant in orthopedics and rehabilitation at the Center for Disabled Children in Banepa, Nepal for about 25 years. And this is so remarkable. He's an honorary professor at the University of Basra, Iraq. He served on many national committees, including Children's Orthopedics in underdeveloped regions of Pediatric Orthopedic Society of North America and the Bone and Joint Decade Commission of POSNA, the Global Causes Committee, and the International Committee of the American Academy of Orthopedic Surgeons, where he directed the International Scholars Program. He's been on the Advisory Board of Orthopedics Overseas Global Help, the Ponseti International, Miracle Feet, and Global Clubfoot Initiative. He has served as a consultant for the World Health Organization in Mongolia and Somalia, and was on the steering committee of the WHO's Global Initiative for Emergency and Essential Surgical Care. He's delivered 400 invited lectures, mostly at international sites, including Nepal, Iran, Iraq. He's also edited a textbook called Global Orthopedics, Caring for Musculoskeletal Conditions. And he's received the President's Call to Service Award for 4,000 hours of community service, the Golden Apple Award, by health volunteers and from the POSNA of North America, the P. Blount Humanitarian Award for Scoliosis Research Society, and the Humanitarian Award from the American Academy of Orthopedic Surgeons. Wow, I mean, that is really a dream CV is what I would say. And who better than him to tell us about his experiences with clubfoot and review this beautiful paper, which is really a milestone in the clubfoot care. Over to you, Dr. David Spiegel. Dr. Viraj Shingade will be moderating this paper. May I request everyone else to mute their microphones except the speaker.
Okay, hopefully everyone can see the slides. I would say it's really a great privilege to be able to present this paper, but I'd like to also add quite a bit of depth to it. So there you can see the hospital in Banepa, Nepal. I would say this is the single most important thing in my entire career. It's been my inspiration, and for 25 years I've had the privilege of being able to spend time here. So trying to figure out how to advance the slide. Okay, so I have no disclosures. And I would simply say that one of the most remarkable human beings I've ever met is Ashok Banskota. He started the hospital about nearly 30 years ago. He's cared for over 100,000 children. He's a wonderful orthopedic surgeon and father and everything. And to me, he's been my mentor, my friend, and so on and so forth. I can't say enough about him. And this is really his work, as well as his son, Bibek, who's with me today. And I feel a little bit embarrassed giving the slides, but I just happen to have the PowerPoint, so I will. Bibek is a phenomenal orthopedic surgeon, and he is now running the hospital. And this is my daughter, Sophie, with him last year in Kathmandu. She calls him uncle for a very good reason. Okay, and there's the family, some of the team at HRDC, because this really is their work. I'm privileged to present it. So what was happening was in 2004, I had just finished studying with Professor Ponseti a couple of years before that. And so I had learned the method, and I chose to live for 6 months at HRDC because I loved it. And so since I had just learned the method, then we started discussing, well, how might this method be of value to the patients at HRDC? So there were two clinical questions that were important. The first question was, number one, within the context of Nepal and HRDC, could this method be transferred and would it be successful in correcting the feet? And the second question was, how far can we push it? And the reason why I say that is because probably 80% of the patients presenting to the hospital were after walking age. And what data was available on that? Professor Ponseti rarely treated a patient older than 2 years of age. So there wasn't published material. So what we said at that point in time was that we should have a standardized data collection mechanism. We should keep track of medical records, because in 10 to 15 years, we're really going to want to know if this worked and what the outcomes were. So that is sort of the framework for how. So the HRDC is about 18 miles outside of Kathmandu on the highway heading east towards the Chinese border. Task sharing is employed. All the casting is done by the physiotherapist. Most of the patients require admission to the hospital. The casts are typically changed at weekly intervals, although that has changed recently. And the inpatient rehabilitation wards have been set up so the appropriate amount of nursing and so on is provided. We downloaded pictures of the braces in 2004, and the braces are made in the workshop with aluminum and with leather. And this has evolved some over the years, but basically the braces are produced for about $6 to $8. And community-based rehabilitation is an essential component of the whole process, being able to track the patients into the village, provide a community resource, troubleshoot, identify relapses, and follow the patients. This system has evolved over the 16 years since it started, in that due to the success at the HRDC hospital, Dr. Banskota and team have set up these 4 satellites to different areas that are now doing the Ponseti method. Our initial paper, published in Clinical Orthopedics in 2009, suggested that extensive soft tissue surgery was avoided in 94% of patients up to 6 years of age. So this is the background for today's paper. So this paper essentially involves following up the initial cohort of patients that were started back in late 2004 when I was living there. And so ultimately we were able to, or they were able to locate 91% of the patients in the villages. You can see at the initial start of the program, patients came from the districts shown in pink. Now, of course, patients from nearly all areas of the country are able to achieve clubfoot care through their mechanism of service delivery. So the study population is 220 feet in 145 patients. More than 90% were located. Okay, so what were the goals of this study? Obviously, we wanted to look and see at longer term follow-up what the clinical findings and patient-reported outcomes were. So the inclusion criteria were idiopathic club feet who did not have any prior treatment. They came between 1 and 5 years of age, so after walking age. They were treated by the Banskota method, and they had a minimum of 10 years of follow-up. Okay, so we went through the Nepal Health Research Council. You saw the inclusion criteria. There was a retrospective chart review component to this. And then a single observer was charged with finding these patients in the village, and it took quite a few months. I might add that this was funded by about a $20,000 grant from Global Health at the Children's Hospital of Philadelphia. And so the prospective component of the data included assessing range of motion with a goniometer, asking the patients to stand and taking digital pictures from all sides, which were reviewed by 2 examiners, looking at gait videos. And I think perhaps the most important thing or unique aspect was to use a patient-reported outcome measure, which was appropriate for children 5 to 16 years of age, the Oxford Ankle-Foot Questionnaire. Okay. So results. Once again, 220 feet and 145 patients. Their average age was 3 years, and the average follow-up was 11 years. The pre-Pirani was 5 and Demiglio was 17. The average number of casts was 8, and as might be expected, nearly all of the patients required some form of surgical intervention. Okay, so here's 220 feet. If we choose to grade success as a plantigrade foot, a flat foot, then
Audience are requested to please mute their mic. Only the speaker will have the mic open. Please. Yeah, Dr.
Okay.
David, please go ahead. Yeah.
Okay, so plantigrade foot was achieved in 95% of those feet. Virtually all of them required surgery, and the majority of surgical cases were the percutaneous tenotomy. And as you can see there, the additional cases, or 10 cases, were judged as failures, and they were treated by a posterior or a posteromedial release. And then additional procedures were required, as you can see there. And all the patients that had a failure of Banskota, they required more than one surgical intervention. These are very difficult feet. Okay, so let's look at the alignment. This alignment, once again, is based on digital images, standing images. So there are some imperfections in that, but I think we have a general idea of how the feet looked or the shape of the feet. So an obvious and complete relapse was observed in only 7 feet. And those are 3 of the feet that you can see there. Undercorrection was fairly common. And in such cases, I think you'd say that the patients were walking with flat feet, but they had residual deformities. And the question is, what's the significance of those deformities? So if we just looked at the hindfoot alignment, about half the patients were in some valgus, neutral 36%, and about nearly 1 in 5 had some varus alignment to the hindfoot, as best as we could tell on the digital images. 1 in 4 had I guess our subjective assessment had some cavus, and then some adductus was seen as well in about 22%. The passive dorsiflexion was 11 degrees, and interestingly, in Ponsetti's long-term follow-ups, the average dorsiflexion was about 9 degrees on bench exam. Passive abduction was about 25 degrees. I'm not sure that there's any good way to quantify or qualify squatting, but based on our assessment with the feet able to be flat, only about 15% of patients could have a normal squat. The remaining modified their squat, essentially dealing with the residual hindfoot equinus. But then comes the most interesting aspect, perhaps, which is that of outcomes. What exactly is the right way to measure outcome? And here's this young man looking at his x-ray, and I mean, does the young man in Philadelphia feel any different than the young man in Kathmandu? So according to whom do we judge outcome? Well, if we conceptualize things according to the World Health Organization's ICF framework, we would suggest that an abnormality in a body function or structure is an impairment, and a clubfoot is an impairment. If a patient with a neglected clubfoot can go to work, has no pain, can have a family and a normal life, then they're probably not too disabled. So what we're most interested in is activities, participation, as a way to look at or grade function. So disability is contextual, as you all know, and this is the interaction of an impairment with the environment. So therefore, a patient-reported outcome measure may not necessarily be as appropriate in different contexts. So the Oxford Ankle-Foot Questionnaire is the only patient-reported outcome that we're aware of that's appropriate for children 5 to 16 years of age. You can have the children fill it out themselves, or you can have a proxy fill it out. And there are 15 questions, 5-point Likert scale. In this situation, we first went through a translation phase as recommended by the developer of the tool. And we've also done a validation study with the numbers that you see there. So our feeling was that after translation and validation, that this was an appropriate tool to use in the Nepali context. So here's what it is: 3 domains: physical activity, school and play, and emotional. And then 1 question about footwear. You can see the Likert scale there, never to always. Let me show you some of the questions just for example. You know, is it difficult to walk or run or stand? Do you have pain, or are you sore, or does your foot feel tired? Very simple and appropriate questions. School and play. Can you do things with your friends? Can you go to the park? Can you participate in physical education, and so on? Emotional. Are you concerned about the way it looks? Has anyone made fun of you? Are you embarrassed? This type of thing. And then finally, has it stopped you from wearing any type of shoes? So the challenge is, so here's the data. The challenge is that this tool really hasn't been applied very often. And so what I have on the right side is the only controlled data that I'm aware of, and that is in non-clubfoot feet. So true controlled data in the study published by Duffy in 2013. So looking at the data here, I think you'd be hard pressed to say that school and play and emotional are any different than controls. Again, I can't do statistical analysis on this because I don't have the raw data. Physical activity, 86% versus 96 on their controls. Footwear, 84% versus 99. So it's difficult to say whether this truly represents a difference, but I think our feeling was that in general, the patient-reported outcomes were reasonable. So we asked some other questions. Most of the patients were satisfied, and they were improved in their daily living, as you can see there. So discussion. This is the only long-term follow-up with more than 10 years in patients treated after walking age with the Ponseti method. So I think that's unique. Initially, about 95% of the feet were flat after the treatment. 1 in 3 had residual deformities, which is not unexpected at treating the older patients. but our impression was that patient-reported outcomes were favorable at 11 years follow-up. Obviously, there's no control group. We lost a whole amount of time in between patients completing their initial treatment and getting their follow-up, but at least we could see what it looked like at an average of 11 years follow-up. And then, of course, we need long-term follow-up with age-appropriate measures. So just looking through the literature, 971 patients of walking age had been reported at short to middle term follow-up. Most authors, technical adaptations, some put each cast on for 2 weeks. Some routinely did an open tendo Achilles lengthening or a posterior release. More casts, that resonates with our paper and makes sense commonly. Of course, as children get older, the degree of passive abduction would be reduced. So we don't expect 70 degrees like in the babies for the Ponseti. This is the reported initial correction to a plantigrade foot. This is the reported average dorsiflexion, 5 to 21 degrees. And this is the reported relapse rate. So obviously with that gap in our study, we had 1 in 3 had residual deformities. So there was an element of relapse in many of the cases, but they didn't come back for follow-up, meaning, or they didn't come back for additional treatment. And then there's a limited number of studies with more than 10 years follow-up on babies treated with the Ponseti method. And those are all coming from North America and Italy. And I think it's important to note that many of the patients had residual deformities, which did not appear to interfere with their function. And so function, once again, did not necessarily correlate with physical findings or with radiographic parameters. So I'll say thank you very much for your interest, and I very much thank and appreciate the doctors Banskota and HRDC. I would say the single most enjoyable part of my entire career. This is their work, and it's a privilege for me to present it. And I'll just open up for any questions and discussion and comments.
Yeah, it is really a wonderful paper, Dr. David. I must congratulate you as well as the whole team and Dr. Banskota. A wonderful paper and very nice work. I think it is a very, because we are also working in the same setup of resource challenge atmosphere, isn't it? So it was really very, absolutely very good paper. There are a couple of questions. We have only 10 minutes, as Rujita has given me, has told that now we have only 10 minutes left. So quite a good number of questions. First, I will go to the audience questions. Rajiv asked, Rajiv Negandhi, that how many patients were treated surgically before you treated them with Ponseti?
None of them were. These were pre-screened to be untreated idiopathic clubfoot.
Okay, so you included only those who were not treated in the past. Only neglected cases you included in your study.
Right.
Was it like that?
None of the patients had previous treatment.
Okay. Second question is, what was your bracing protocol? As is a question. What was your bracing protocol?
So I think this is a very, this is another limitation which I should have mentioned. The braces are fabricated. The braces are recommended as recommended by Professor Ponseti. And in the walking age children, obviously we didn't go with a 3-month program of full-time use because it was impossible. They just went right to the nighttime use. But this is an absolute criticism in that we don't know what the wear schedule was. Most of the patients' families said that they wore the brace, but we can't prove that. Basically, all we can do is say, here's what they looked like 11 years later.
The another question is, was there a difference in Oxford score between male and female? Scores between male and female. Did you find any kind of difference in your study for the scores?
I apologize, that statistical comparison was not completed.
Now, can I ask some question from my side, Dr. David and Dr. Banskota? Let me again congratulate you for the wonderful paper and a wonderful study, because I do get a lot of neglected clubfoot cases in the central part of the India, because a lot of tribal area is there. So we know how difficult it is to get a follow-up. We also do the same protocol, that going into houses and then have their follow-up, long-term follow-up. Now, a couple of questions. One is in your figure 1, you mentioned that out of that first, the 95% success rate was there. Most 95% patients, they have correction. And then few success were in 2000, I think 210 patients, right? And then there was failure in 10 cases, that is 5% cases who require PMR or other kind of thing. So what do you think over now, having this follow-up, what do you think could be the cause of the failures in your series? What could be the factors? What could be the cause?
Well, I'll take a guess, but then I'll ask Bebek. I'm sure that there were some patients in there who were not idiopathic club feet, perhaps, or perhaps there were something like there could be a tethered cord that was not recognized or other subtle neuromuscular diagnosis. And then, I think that there are just some club feet that are extremely difficult, and they're resistant to virtually every type of management. And I think I was surprised that 95% could get a flat foot in walking age. I wouldn't have thought it would have been that high. The other thing I would say is that, when you've got a center where two or three people are doing thousands and thousands of casts, the physios, I'm afraid to put on a cast in front of them. So they have become true experts in getting these corrections, I think. Bebek, I don't know if you have any comments.
So you feel that it was the rigidity or the complexity of the foot itself rather than technique. Am I right? So it was the inherent rigidity of the foot or the complexity of the pathology itself that has caused the failures, right? Okay. Now, yeah, you want to say something, Dr. David?
I totally agree with Dave, because just a couple of weeks ago, we had one patient who was just 7 months old, but we just, can't seem to get it straight with Ponseti. So we have known this, that it's not just the age, but, even younger children can have rigid feet, as well as, older children can have, some of the older ones can have very flexible feet that are very responsive to Ponseti. The other reason might be bracing dropout, as Alaric will know, especially in difficult geographical regions, we have no means to control that. Sometimes we see kids who come back for follow-up after 6 months or 1 year, and they are wearing this torn brace that is not effective anymore. It's just like an open shoe. And that is a common sight at HRDC. So that might have contributed. And one more point I'd like to make is, Dave has really emphasized this point. It's so contextual, In Nepal, when we treat a child from the plains and we achieve a dorsiflexion of 10 degrees or 9 degrees, they are very happy. But if that guy lives near Mount Everest, there's virtually no plain out there. Every terrain is an incline. So he's not happy with the same degree of correction that you might have achieved. So I think patient-reported outcomes are so relevant to kind of, actually knowing how, how to deliver these cases for different geographic regions also. Thank you.
Another question is, Dr. David, as we know that if you follow the principle of Ponseti, there has to be an unlocking of the calcaneum from the talus. Am I right? So with these neglected cases with altered anatomy and altered bony structures, how do we explain the unlocking of the calcaneum or the talus if we go by if we call it as a Ponseti technique?
Yeah, I think without routine x-rays or perhaps ultrasound or other means, I'm not sure exactly what happens. Given the degree of residual deformities, I think we're all looking to get a flat foot that suits the patient. It doesn't hurt and that they can walk on. But I don't think that you get the radiographic correction or the, how do you say it, reversal of the pathoanatomic changes in older patients. I think probably remodeling of the chondroactive structures is more limited. So I think somehow, some way the foot gets flat, but there are residual deformities of the subtalar joint, or of the, I guess you'd say, the talocalcaneonavicular complex.
So,
Do you feel, Dr. David, that
questions?
Yeah.
Hello, can I ask a question,
Yes,
Mira, if you don't mind?
Yes, Sandeep. Yeah, please.
So, Dr. David Spiegel, that was a wonderful and an honest paper and lovely answers too. My question to you is that is this paper with its findings can be extrapolated to high income group countries and middle income group countries, because the study is essentially in low income group countries where expectations are not so high?
Well, I think that context is everything, as Bibek said, and we emphasize. And one of the reviewers of the paper appropriately pointed out that, in my practice, this would all be unacceptable. So beauty is in the eyes of the beholder. And I don't think, how can I say it? In certain areas of I'm sure in certain people in Philadelphia or certain areas of the United States, patients would not be satisfied with some of these.
Absolutely.
However, how can I say it? Our treatment choices with our patients, we outline the pros and cons of different options and the downside to things. And, there's certainly challenges with extensive soft tissue and osseous surgery. So I think in the end, when we think about the most important principle, which is a planograde foot that's painless and has a reasonable range of motion, that's why I think these results are very important.
So Viraj, we'll take some more questions because I think there are quite a few people interested, and I think clubfoot is something so close to everyone's heart. Let's not disappoint the people. Iswaran or Dr. Dimutu had a question. I can see that. Yeah.
What was the reason for majority got heel raise on squatting? Is it due to flat top talus? Dr. Dimutu has asked this question.
I think that all of the patients, even successfully treated, don't have normal dorsiflexion. And Ponsetti's long-term studies have shown an average of 9 degrees dorsiflexion, which in patients treated in infancy, which isn't distinctly different from what we had measured. His point was that during ambulation, there's probably greater dorsiflexion than one can assess on bench examination. Now, you can have a lack of dorsiflexion at the ankle, so it could be some midfoot cavus, it could be ankle equinus, or it could be flat top talus. But in the absence of routinely getting x-rays or arthrograms or some advanced study like an MRI, I'm not sure. I think we get a sense that when there's a very hard endpoint to dorsiflexion, that perhaps there's a greater likelihood of being a flat top talus. So I think you're right. I think many cases have a flat top talus, and this may explain the lack of dorsiflexion.
Anytime you feel that there is a requirement of osteotomy to correct the residual deformity, osteotomy.
I'm sorry?
And anytime did you feel that you require osteotomy, a bony procedure for the correction of residual deformity?
I think only 1 or 2 patients in the whole series ended up getting any type of extensive surgery. So I'm sure if you asked the doctors and you were very scientific about it and you treated impairments rather than disability, you would get standing x-rays, draw your angles, you would do osteotomies, and you would shoot to normalize the radiographic parameters and the shape of the foot. However, for whatever reason, the patients didn't choose to pursue any additional surgical management because I guess they were able to do their activities of daily living and they were satisfied.
I think your last question. Yeah.
And there's a question from Dr. Sponsor, Viraj.
Sponsor, yeah. Dr. Sponsor, he has asked, David, will you be able to follow these patients into adulthood? Follow up till adulthood. Do you have the follow-up of these patients till adulthood?
Yeah, so I think that we would absolutely like to do that, and I would, and Vivek can address that, but I would also say that, we have another, in the British Journal, we published a paper in 2013 on 5 to 10-year-olds with the Ponsetti, and so we've just got a little bit of funding to try to study that group at a minimum of, well, now it would be a minimum of 10 years follow-up to see how they ended up. So yes, I think it would take the CBR network and to find the patients. typically they don't move around all that much. My understanding is, so you can find them. Vivek, what do you think?
Absolutely. I mean, it'd be very exciting to follow them up. And I think now with social media, it's become easier, because when we tracked all these patients in the villages, one thing we've done is we've created a Facebook group of all our club feed patients, you know. So even if they leave the country or something, or we need some resources, we have some very savvy fellows in our IT team, you know, who just use their mobile phones. So hopefully 10 years later, that's going to work, you know.
Thank you, Dr. Banskota and Dr. David. It was really a wonderful paper. Absolutely. I mean, we all should congratulate all the authors and for their great efforts. Over to you, Rujita, because I think we are time up for the first paper. Yeah.
Yeah, so that has been a very, very enlightening paper, and especially a subject which all of us really share the problems as well as the solutions equally. So I think that's very enlightening, and thank you so much, Dr. Spiegel. It's always been a pleasure to be working with you on all fronts. It's my equal pleasure to introduce Dr. Paul Sponsella now. We really have stalwarts today, and who better than Dr. Sponsella, who joined the Johns Hopkins staff in 1986 and is currently the division head of the pediatric orthopedic division. He performs non-surgical and surgical treatment of spine deformity as one of his main interests. His research interests include pediatric spine, etiology, and treatment. He's authored almost 300 peer-reviewed scientific papers and has written or contributed to more than 85 books, book chapters, and articles. He's a member of numerous clinical study groups, including HARMS study group, pediatric spine study group, cervical spine study group, and FOX study group, and others. He's honored on several occasions for teaching and research. Dr. Sponsella was named Outstanding Teacher by the Union Memorial Orthopedic Program and was twice awarded Teacher of the Year in Orthopedic Surgery by the Johns Hopkins School of Medicine. He's also received the National Marfan Foundation Hero with a Heart Award, as well as the Arthur Hune Award for Career Research by Pediatric Orthopedic Society of North America. Dr. Sponsella has traveled to Guyana, South America on 3 separate occasions to volunteer for Project Dawn, and he has a number of several medical boards, and including the president of the SRS Research Council Chair, Board of Directors for Pediatric POSNA, and Professional Advisory Board Member of the National Marfan Foundation. He's the Deputy Editor for Pediatrics of JBJS, Deputy Editor of Spine Deformity, and a reviewer for many journals. Welcome, Dr. Sponsella. Besides spine, I think his sheer versatility shows in right from supracondylar fractures to even complex pelvic osteotomies. So what a pleasure, and may I request you to take stage now.
I will also add, Rujita, that when I invited Dr. Sponsella and I wrote to him, despite his very busy schedule, within a couple of days, he immediately wrote back and said, I'm more than happy to do this for you all. And not only that, he even invited his co-author, and I'd like to welcome him as well, Stuart Mitchell, who's the first author of this paper, is also joining us from POSNA. So it just shows the level of dedication. He's busy at the conference there, but he's still attending here to be with us at this discussion.
Wow, that's
so welcome
amazing.
both Dr. Sponsella and Stuart.
Thank you. Thank you very much for the invitation and for asking me to discuss this article. I'd like to acknowledge our first author, Stuart Mitchell, who is on this Zoom as well, and is also with Dave Spiegel at Philadelphia currently, and will be joining Dr. Jim Sanders at UNC. So this is about pediatric Gartland type 4 supracondylar fractures, and we found they have substantial overlap with flexion type fractures. My disclosures are shown here, none relevant to this presentation. I think we've all been there, trying to gauge the right amount of time to fit a supracondylar fracture into a busy day. Of course, many of them are satisfying and quick and make you look really good, but others can destroy confidence and take extra time. And this seems to be related to the presence or absence of a periosteal hinge, which make reduction and pinning harder if it's not there. The purpose of this study was to try to identify these fractures and allow us to plan more appropriately and be prepared. For this study, we teamed up with Dallas Children's Hospital, which has a large number of supracondylar fractures in a database studied by Christine Ho, and she was one of the co-authors of this. I also enlisted Josh Abzug, who has an upper extremity interest, and Stuart Mitchell did the vast majority of the work. We retrospectively studied all supracondylar fractures at these two centers who had surgery from 2008 to 2016. And these, of course, were not the type 1 and type 2s, but all the operative types. Over 3,000 patients were included in this database from the two sites. And we focused really on type 4 fractures. And these, as you may know, are diagnosed by only intraoperative behavior of the fracture. In other words, the lack of both an anterior and a posterior periosteal hinge from the surgeon's note. We compared these rare type 4 fractures with the type 3s, and we matched them 4-to-1 so that we could do a thorough chart review on the number of type 3s that would take to inform us on the comparison with the type 4s. Patient characteristics were extracted from the charts, and the X-ray variables were studied by 4 fellowship-trained pediatric orthopedic surgeons listed on the author list here. And we hypothesized that there will be a number of clinical as well as radiographic predictors that can help you increase your index of suspicion that the fracture could be a type 4 when you get to the OR with it. We found that there were 39 type 4 fractures, which was only 1.3% of the total in this database. So the results, in fact, there were not any clinical predictors of type 4 fractures. Age was not a predictor. An open fracture was not a predictor. Presence of a neurologic deficit, nor obesity were predictors. So really, we could not predict it based on clinical factors. However, we found 5 statistically significant radiographic predictors from the ratings done by the 4 surgeons. Most importantly, flexion angulation was a predictor, and the odds ratio are seen on the second row here of this table. Stuart put this nice pictorial together, and flexion angulation had an odds ratio of 17 times. Valgus angulation and lateral translation kind of went together, and they had 5 to 6 times odds ratio. And interestingly, osseous apposition, where the fracture was complete, but it was still touching, had an odds ratio of 4 times, and in fact was present in almost 2/3 of these type 4 fractures. And an example of that is shown on the bottom row of this table. There were also some significant results in treatment, which are probably intuitive to your own experience. Type 4 fractures took longer in the operating room. We define time as from time out until stop of anesthesia. For the type 4 fractures, took 20 minutes longer. And since the working period of these fractures for the surgeon is about 20 minutes, that's a doubling of the fracture time. And there was also a much larger standard deviation in the type 4s, up to 45 minutes. So some of these ran into more than an hour to an hour and a half. And 13% of the type 4s required open reduction versus only 3% of the type 3 fractures. Of course, there are limitations in this study. Being retrospective, we had to glean the type 4 designation from the operative note, so it may underestimate that. However, both of us, Christine and myself, have been envisioning this study for a number of years, and so we were pretty careful to try to make sure that all the type 4s were picked up and documented between us and our partners, because I review all the Hopkins operative fractures myself and our trauma boards. So in summary, this paper was the largest study of type 4 fractures, and I think it hopefully provided helpful information to predict and help you understand the behavior and the demands of the type 4 fractures. It was interesting that we realized substantial overlap between type 4 supracondylar fractures and the flexion types. And interestingly, probably most novel was the radiographic feature of cortical opposition or cortical overlap. In other words, it's not the most displaced way back fracture. It's actually touching, even though the cortex is disrupted. So that, I think, has really opened my eyes a lot. So we hope that this information will be valuable in helping you understand these fracture parameters and plan your treatment accordingly. So thank you very much for allowing Stuart and myself to be part of this. Stuart, do you have any comments since you did all this work?
No, I think you covered it very well. I think one important factor in that we're curious looking now is the overlap with deflection type fractures. So I think we're going to go back and do kind of the opposite direction and see how things go from there.
Good. Thank you.
Thank you very much, Dr. Sponseller, for this excellent presentation of this very important work. A few questions which we had. One is, how do you plan for standardization of X-rays pre-operatively? So if you have a traumatized elbow, is there any way in which you have standardized X-rays, or had you excluded any X-rays which were not standardized in your study?
We excluded a couple that did not have two views, but I think in a painful elbow, which may already be splinted, we didn't have any further standardization, and then just making sure that we had some degree of an AP and lateral on both views of a patient. But since there's often some degree of rotation, we didn't have anything more than that. I'm interested in what you may be getting at. Is there a better way to do that that I'm not envisioning?
No, so that was one thing, because it is very difficult to get a good standard X-ray in a traumatized elbow, especially when there's a lot of swelling, or if it has splinted, it has been splinted. So
yes.
Whether
especially
that
if they're flexed.
Yes, sir. So whether that makes any difference in the way you measure these values?
No, I think you're right. It's almost never a fully extended elbow because it's in pain and it's in splints. So you have to take that into account as well.
Right. Sir, on the basis of this article, have you changed your management in any way, in a way in which if you get an X-ray, what are the planning which goes into the operating room when you see an X-ray which fits in any of these criteria?
I think it's more of a practical difference. When we see one that we are now concerned with, I think I can recognize these a lot better by looking at the X-rays. And so I will more often kind of scrub in and make sure that I'm there to help the resident, right from the start, instead of letting them kind of be taking the reins. Usually I can get these still closed by advancing the pins, and then I will get one of the pins across the fracture site and use it to toggle and realign and get the two pieces together. And then you can typically pin them closed by getting engagement of one pin and rotating around it. So I think I just have myself better mentally prepared and more engaged for these ones that I'm worried about. And I think it also helps us to understand the behavior of the fractures, especially the ones we're calling flexion types, and be more prepared to look for ulnar nerve deficits, document those as well, and avoid medial pinning in those as well.
I think Dr. Avisha has asked almost a similar question about the recommended method to reduce these fractures. And I'll go one step further. So is there any difference in the recommended method of fixation or treating a flexion supracondylar versus a frank type 4 supracondylar?
We didn't study that, but I think everyone has been moving, largely to lateral pinning. And in these cases, I would be less hesitant to do medial and lateral pinning if you have a big enough bony column on the medial side that you can get good purchase. So I think you can be prepared to do that. I think that is a helpful way to get them reduced close. And certainly I would always use at least 3 lateral pins, if not medial and lateral pins. I think that could be a project for further study, perhaps. Now that we are accumulating a reasonable number of type 4 fractures, we could study the ability of these different constructs to maintain adequate alignment to healing.
Right.
Dave, do you have any tips from your methods at CHOP?
Well, I think, you've actually put into a table, it's wonderful, So when I see those things, and I do have read and studied the article, first thing I ask for is a hand table because I recognize that there's going to be rotational instability at the fracture site. And so I think our experience has been that, yes, these are much more of a struggle and difficult, that they have to be pinned without rotating the elbow. So we realign in the coronal plane, and then we get the pins in, and then we, or at least my experience is that you have to adjust the degree of flexion of the elbow. Sometimes, it can only be 70 to 80 degrees of flexion, and then pin by moving the machine from the AP to the lateral rather than moving the elbow. And even then it's sometimes a challenge. And again, there are guidelines against using a medial pin, but just a couple of days ago, I used one for a similar fracture because I feel they're just rotationally very unstable. So once I get my lateral pins in, then I'm more comfortable rotating it, making a small cut down of 1 centimeter, finding the epicondyle, and then placing the pin.
I think Dr. Sandeep Patwardhan had a question first.
Yeah, Dr. Sponseller, again, wonderful paper. It was a pleasure to listen to you. A couple of questions. First was that in your clinical criteria, you said nothing correlated. Did you look at ulnar nerve paresis and medial bruising as clinical signs to suggest an unstable or a flexion variant?
That's a great question. We didn't look at that in part because I think the description wasn't always accurate, but we did look at something closely related to that, which is radiographically, we looked at the ones where the bone was really at the skin envelope. In other words, where it looked like it was almost ready to come out the skin. And you could probably tell that better from the x-ray than you could from the clinical description in the chart. And what we found was that that particular variable was not correlated, if I recall correctly. Is that true, Stuart?
Yes, sir, that's correct.
Okay. So with a valgus angulation and the medial spike coming out from the medial side, you found no bruising on the medial side. Is that what you're saying?
We found that it was not statistically predictive of one fracture type versus the other.
All right. Okay. And the second question was, of the 13% that you said needed open reduction, were they all operated by residents, or were you there where you tried the percutaneous joysticking to get a closed reduction?
This study spanned, 8 years, and it spanned a number of surgeons. At Hopkins, the attending is at least in the room, if not scrubbed. My preference is to be scrubbed myself. And I think that's probably true in both locations. But I think that the way we do it now is more akin to what you described, which is engaging the two fragments provisionally and then advancing the pins with careful control of the flexion extension, and sometimes moving the machine if necessary instead of the patient. So I think we're evolving toward a more planned way of treating these and getting more of them closed. But it's not the worst thing in the world if you have to open them, I think. I think it's maybe a point of pride more than it should be.
So we have a question, Dr. Rujita Mehta has asked about any special position for C-arm placement, and are there any special views in which it can help you with the reduction and fixation?
Yeah, I think as Dr. Spiegel said, using the hand table so you don't have to depend on keeping the floor in one position, and being able to spin that from AP and lateral is a good way to do it. Other than that, I don't think we have any things that you haven't already discussed during this presentation.
I think Dr. Alrica Rujus had one question.
Yes, thanks, Mandar. So, Dr. Sponseller and Stuart, I just had a question again to clarify regarding the diagnosis of type 4. It was almost always an intraoperative classification, because I think preoperatively, as Mandar had said, it's impossible to get really good views. Most of the time, you end up getting an oblique X-ray, neither an AP nor a good lateral X-ray. So intraoperatively, was it a diagnosis that you made clinically saying that the fracture was really unstable and you could not reduce it? Or was it primarily radiological or a combination of both?
Yes, thanks for asking that question. The way type 4s are defined is that it is purely a motion diagnosis. So you are testing the fracture in both flexion and extension. And nowadays, we are more rarely trying reductions in the ER for these. So we're not really typically getting a chance to stress them in both directions. So it's really an intraoperative, it's an intraoperative real-time imaging, but there is no a priori radiographic classification or criterion for type 4. It's always been and remains a diagnosis based on the mobility and the presence or absence of that periosteal hinge. So admittedly, if you were trying to reduce these in the ED, you could try to determine that. But in this case, it is almost always done in the OR.
We had one more question, Mandar. I think you need to look at that.
Yes. So Avi has asked whether there was any special association with neurovascular injuries which were seen with this type of cohort.
No, we specifically studied that and found they were not more common in the type 4s than they were in type 3s. They were both equally at risk for those types of neurologic and vascular injuries. And in fact, type 3 probably is arguably more worrisome because the neurovascular structures are tented, stretched, and thrust against the proximal metaphysis.
Yeah.
Well, the final thing that I really had a little trouble to understand was about the cortical apposition, which 64% of your patients, it goes against the definition of a multidirectional instability. On one side, we're saying it's a type 4, which is really unstable, and then still 2/3 of the patients had evidence of cortical apposition. So I'm not able to reconcile those two things together. So how do you explain that, Dr. Sponsella?
Well, I think that the mechanism probably involves more direct load, and clearly with the cortex completely violated circumferentially and often even comminuted, there is a tremendous amount of energy, but it probably involves less of a pure hyperextension bending backwards, but more of a direct load impact, and that somehow tears the periosteum anteriorly and posteriorly instead of hyperextending and preserving the posterior periosteum. Beyond that, I can't say, but it probably is a topic that will help us to, it could be perhaps biomechanically studied to see how you can produce this pattern and tear both anterior and posterior periosteum.
Great. So I think we are almost out of time. And thank you, Dr. Sponseller and Dr. Mitchell, for this fantastic lecture on a very, very interesting and very difficult topic, which we sometimes have to manage. Type 4 supracondylar is something which we are always scared of. And as Dr. Sponseller said in the first slide, sometimes we become too cocky in trying to, being very confident in managing supracondylars, and suddenly God gives us a type 4 in which all our cockiness comes down. So yes. I'll hand over the mic to Dr. Alric Arujas for his summing up and vote of thanks.
Thanks, Mandar. I think I'll ask Dhiren, who is our president of POSI, to give us a short vote of thanks. Dhiren, over to you.
Thank you, Dr. Spiegel, Dr. Sponseller, Vivek, and Dr. Stewart. First of all, thank you very much for accepting the invitation and sharing your valuable time on the Saturday morning. I know that some of you are from the POSI meeting, so we really appreciate your commitment for this program. I also thank our POSI members and the young orthopedic surgeons who have shown a keen interest in asking very important questions, practical questions on these two important topics. So with that, I once again thank you, and I wish safety to all of you and to your family, and see you during the upcoming POSI webinar on the 19th. Thank you.
Thank you.
everyone.
Thank you very much for
Thank you
including us.
taking your time and
Thank
really great papers. And thank you so much.
Bye.
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 Bye-bye.
Stay safe. Bye-bye.